Good morning, everyone. Thank you very much for the introduction. These are my disclosures. Well, it's not easy to speak at an industry-sponsored symposium because I don't want to be that guy here saying that this is the best machine or the best technology ever. And I don't want you to be these guys here which are just sleeping, waiting for the lunch. So it's a bit tough. And I say, okay, why not begin with a quiz? So I'm sorry, there is no polling system here, so we'll have to do with the hands raised. So which one do you think between A or B is a sub-millisievert coronary CTA? So which one will say B? Okay, which one will say A? It's a bit of a mixed results. And there is a trap because the real answer is it depends. And it depends of what? It depends of the conversion factor that you are using. And I think that's something important to know because most of the literature is still referring to the conversion factor used for chest, which is 0.014, which has been published a long time ago. But last year, there has been an interesting publication in JACC Imaging where they've demonstrated that specifically for cardiac imaging, it might be more accurate to use a dedicated conversion factor, which is higher. And they suggested in this publication to use a conversion factor of 0.026. So if we want to be below the millisievert, with the conversion factor of the chest, we have to have a DLP below 70. And with the conversion factor dedicated for cardiac, it means that the DLP is below 38. So, okay, let's be optimistic. Let's go with the higher conversion factor. So now, which one do you think is still below a millisievert? A? Anyone? B? Anyone? Okay, so it's also a trap because both images are from the same patient. So maybe you saw that coming. And what are the differences between both images? If you look at the DLP where we are just below the millisievert, and these images look less noisy than this one. And of course, the difference between the both is just that the reconstruction algorithm that was used. Here, image A, it's the standard iterative reconstruction. This is AIDER 3D. Here, it's the deep learning reconstruction, which is called ACE. And you see that you have a significant decrease in the image noise, as well as an improvement of the image quality. Okay, so now you will tell me, you were saying in the beginning that you don't want to say that this is the best technology ever, but this is like a never-ending story. We've heard that multiple times before. First, it was filtered bulk projection versus iterative reconstruction. Then it was iterative reconstruction versus model-based iterative reconstruction. And now you want to speak of IR versus DLR. Okay, we all know the story. DLR, the newest algorithm, would just smash iterative reconstruction, better image quality, less noise, less radiation dose. Okay, it's the same story everywhere. I think it's the same story, but not that exactly identical. We have a significant twist, and the twist is how this algorithm is working. And during the next 20 minutes or so, I want to share with you how is DLR working, and we'll see if it is efficient, if it is dangerous, and how it improves or impacts the workflow. So first question, how is deep learning reconstruction working? So we already had amazing topics this morning about deep learning. So I will just say really very, very, very simple so that everyone can understand. Well, if we think of artificial intelligence, what we have is we have an input, we give it to the algorithm, the AI, and we get an output. So we have this, we want the output, so we need the algorithm. And in order to build the algorithm, we have different options. And one of these options, which is the most recent one and probably one of the most effective one, is deep learning, which means that in deep learning, we are building the algorithm with training data sets, which means that we have matched pairs, input and the matched output, and we feed the machine with these pairs. And this will be able to obtain the algorithm in the end. So we do this using a convolutional neural networks, which means that how is the algorithm built? Let's say that, for example, the input is an image, for example, chest X-ray, and the output is the chest X-ray normal or is the chest X-ray abnormal? Well, the convolutional neural networks is working in different layers. So each layers do a little bit of a transformation of the image. It's a convolution. We have different layers that are successive. And the way the algorithm connects all the layers, so do the path between all the layers, is based on the example of the training data set that will feed the machine. So we have, for example, one input, which is a chest X-ray, and we know that the chest X-ray is normal. So we have matched pair. And this will be used at each convolution to go through one specific path to go, for example, normal or abnormal. And the more we feed data to the algorithm, then the more precise the paths are, and the more precise and the more efficient the overall algorithm is. Which means that if you want to get sufficient efficiency, you need to feed the algorithm with at least enough data. And the more complex the algorithm is, which means that the more layer you have, well, the more data you will need for it to be efficient. So how can we apply this to DLR? Well, it's very simple. The input is a noisy image, and the output, what we want to achieve, is a noiseless or as noiseless as possible images. So now there is a question, how can you obtain noiseless images? So of course it's not fully noiseless, it's as noiseless as possible. This is obtained with examination that are acquired with very high tube current, so a higher radiation dose than usual, and which are reconstructed with advanced model-based iterative reconstruction with a higher number of iteration and a more advanced modeling of all the system optics, physics, and so on. Which means that in order to get these images, you need a few hours of reconstruction. And then you have the noisy images. This is the images reconstructed with the usual iterative reconstruction algorithm that you can add over it simulated noise to simulate different level of radiations. Which means that for a patient that was acquired with very high tube current and reconstructed with advanced MBR, we have different level of noisy imagination. So one examination, one patient, will give us multiple pairs of images to train the network. So this is an example from the literature. This is the target image, so higher dose, and this is the image that we give as an input with either the same dose but with iterative reconstruction or either a lower dose. And then we feed the machine with all these training data sets. So this is thousands and thousands of training data sets. And the convolutional neural network is built using all these examples. So this is built in the factory. And then we understand that this algorithm is trained to go from here to here, and the difference from here to here is just noise. So this algorithm is trained to recognize and to eliminate noise. So on site, when we are on the clinical work, how is it working? We have the raw data, we have a little bit of data domain filtering, then everything is reconstructed using the usual iterative reconstruction algorithm. And then we apply the CNN, and then we get the final image which has been denoised. So it's not technically a real reconstruction-based algorithm. It's more a deep learning-based denoising. Okay, so we've seen how is it working. The question is it efficient? So first point is, and I think it's the most important one, is the image quality. So these are the same images, 55-year-old patient with low BMI, DLP was 33. Okay, this has been reconstructed with the usual iterative reconstruction, IDR's 3D. This with model-based iterative reconstruction first, which is supposed to be like the standard of care, and here with deep learning reconstruction ACE. So when we compare the image quality on this curved MPR, this looks probably the best, the MBIR, with the lowest noise, and this approaches the MBIR with an image quality that is less noisier than the iterative reconstruction. But this is on curved MPR. When we look at the initial axel slices, and when we zoom in, then you can recognize a little bit of the defaults of the MBIR algorithm, is that the appearance of the images are not really natural. When you look, for example, here at the myocardium, it's smooth, there is no noise, but it doesn't look natural. When you look at here the shape of the trabeculations, or for example the borders here of the LA, okay, it's nice, there is no noise, but the appearance is not satisfying. When you look here at the DLR, its noise has significantly lowered coming from the IR, but the overall appearance stays natural. And so visually, the image quality of DLR algorithm is pleasant. And this is, I think, a major advance compared to the plasticky or artificial aspect of MBIR. Second point, what about the noise reduction? Okay, let's say this example, 62-year-old women, 34 BMI, heart rate 63. We achieved a radiation dose of only 46, so a little above the millisievert. And when we do some measurements inside the ascending aorta or the pulmonary artery, we see that we have here reconstructed with iterative reconstruction a noise of 45 or 36 that goes down to 24 or 19. So we achieve about 40 to 50% reduction in noise. This reduction is consistent across all structures. Let it be the myocardium, the blood pool, the subcutaneous fat, or even the liver. So the algorithm is agnostic to the location of what is inside the image. It's working for all across the images. And the reduction is in the same range for everything, about 40 to 50%. So when we compare this to the literature, currently there is only one publication about DLR usage is in coronary CTA. This is the initial publication using the training data set for the algorithm. They've achieved a noise reduction of 20%. So you see this is the IR, this is the DLR reconstruction published here in this paper. So you say, okay, in the clinical routine we achieved 50%. Here in the literature they achieved only 20%. Yeah, but remember that this was done on the training data set, where the dose initially was higher because they wanted to get these noiseless images. So already, even with IR, the noise is already very, very low. So probably what you gain is less than what you will gain in real life. Third question, what about spatial resolution? So do DLR increase the spatial resolution? So you might think that DLR could increase spatial resolution because as it is trained to mimic MBIR, and MBIR has proven to increase the spatial resolution, so maybe DLR will also increase spatial resolution. So here is an example of an SMA stent. And if we zoom in, this is DLR, this is IR. And if we look, for example, here or here at the interval between the struts of the stent, it looks a bit more higher resolution here with less blooming artifact compared to IDR. When we compare to first, probably first, so MBIR remains a bit better in terms of the improvement of spatial resolution. So spatial resolution might be a bit improved, but this is yet to be proven. Third point, what about the radiation dose? So we've seen that with this algorithm, it is possible to lower significantly the noise. So if we want to achieve the same level of noise, we can lower significantly the radiation dose. And what is nice is that ACE is built into the auto-MA modulation, which means that having the reduction designed for the specific algorithm is already embedded in the machine. And you have almost no time-consuming optimization to do. So here is an example. We had our machine with IR for 14 months, so IDR 3D. Then we upgraded to ACE, same machine for 3 months. And just to show you, this is a very simple analysis to show you the DLP difference between both machines just by the introduction of the DLR algorithm. So the dose reduction is about 30% across 30 to 40% across all examination. And I think what is most impressive is for head CT. You know that for head CT, it's very difficult to lower the dose because you have the skull to go through. And even that, well, you can achieve significantly lower level with at least like identical or even better image quality. And finally, about the results, can we also reduce the iodine load? Yes, we can, because with this type of algorithm, it is possible to do imaging, so CTA, at 80 kV, which was a bit more difficult before. So here is an example. This is a patient, 95 kilograms, so not a thin patient, with impaired renal function, and we had to follow up the fenestrated EVAR. So we did the acquisition with 80 kV, so we were able to lower the total iodine load, and of course lower also the radiation dose. And if we compare with prior examination done on the same machine the year before with IDR, so here the machine selected 120 kV for the acquisition compared to 80 kV for the follow-up examination. You see that the image quality is the same, but here half the dose and more than half the radiation dose. Okay, so now comes the interesting question. Is this algorithm dangerous? Maybe you've seen that. It has been widespread in the papers earlier this year, saying that they were able, a group of researchers were able to inject, using deep learning, false pulmonary nodules into chest X-rays. And when you look at the images, you say, okay, this looks real. So the question is, can this algorithm create or erase some lesions or some images? Well, technically the answer is no, because as we saw earlier, the algorithm is only trained to recognize noise, and noise only, whatever the body part or whatever the underlying lesions. So it will just remove noise. Well, this is the theory. But, of course, the algorithm has not been trained on all possibilities. And in our initial experience, we think that it might be limited for very low dose examinations. So I will show you an extreme example. This is chest CT that we wanted to acquire at the lowest dose possible. So we go for the lowest kV, lowest MA. Total DLP was 1. This is reconstructed with IDR. This is reconstructed with ACE. You see that there is almost no difference in between. So at very, very, very low dose, maybe ACE is not efficient enough to remove the noise. So what could happen? This is an example that we encountered. 34-year-old man, so not super fit but not obese, BMI 28. And he was referred to us for atypical chest pain and positive family history. Okay, so we were pretty sure that the examination would be normal, so we wanted to lower the dose as much as possible because he was young. And we say, okay, he's not super thin, but let's try and do 80 kV coronary CTA. This is what we obtained with ACE, and you see in the mid-LAD, it looks like there are like some hyperdense lesions here and maybe a hypodense lesion here. Not sure. This is surprising. And when we saw that, We saw also here some hyperdense lesion, maybe here, maybe here, maybe here as well. Not sure what it is. So we decided to do the reconstruction with the usual iterative reconstruction, IDER. So you see that, of course, the noise here is way, way higher. So images are really noisy. You can maybe see something here, but it's difficult to tell if it's just noise or if it's a true lesion. So what we decided is we decided to rescan the patient, this time at 100 kV, and of course the LAD is normal here. So what happened here? We think that the dose was probably too low for this patient, and some artifact appeared, and on ACE DLR, the background noise is removed, which means that some artifacts can stay and be more prominent. So I wouldn't call that a creation of a false image, but it's more like an artifact of the algorithm. Last question, how does DLR impact the workflow? Well, that's the major advantage of DLR, its speed. We've seen this morning that this is thanks to the GPU. And the reconstruction unit of our CT is as small as this. I've put my professional phone just for size. So you see it's very small. We have 8 NVIDIA GPU. This is one GPU. We have 8. So just for the geeks out there, the power supplies is like 4,800 watts. So this is a lot. And the speed of reconstruction is about 40 images per second. So IDER 3D is 60 images per second. So this is almost the same as iterative reconstruction. Basically, and in clinical routine, it has absolutely no impact on the workflow. A little bit about future development. So future development for this kind of algorithm is probably to increase the quality at low kV. We see with 80 kV that it might get some limited problems. To increase the efficiency at very, very low dose, extreme low dose, and also the availability for entry and mid-level scanner. Currently, this is something which is commercially available for high-end scanner, but the availability for mid-level and entry-level scanner is probably coming. So as a conclusion, as we saw this morning, and as you are seeing everywhere, AI is really buzzing in radiology. Look just at the RSNA program. When you just search for deep learning, you see that the number of sessions concerned is exponentially increasing. Deep learning reconstruction, I think, is one of the first commercially available applications of AI in imaging. This is something that we use routinely on all our examinations in our department. So not only cardiac, everything, head, chest, abdomen and pelvis, bone, everything. The image quality is visually praised by radiologists and by our clinicians. We get impressive results on dosimetry. All this without any impact on the workflow. So in my opinion, it will most likely become a new standard in the near future. The same as we transition from FBP to IR, I think we will transition from IR directly to DLR. Well, I thank you for your attention, and the floor is open for questions.
Thank you very much for this overview. I think it's a real nice example, clinical example of the benefits of AR. We have time for one question. I have one. Do you use it for every examination, or do you select cases?
No, every examination. Yeah.
Okay, I'd like to thank both speakers, and I'd like to thank you for your attention, and have a nice dinner. Thank you.
Thank you.